Yeah, my name's Howard Danzig. I'm quite frankly the instigator of the ECHIC group, and ECHIC is the acronym for Employers Committed to Control Health Insurance Costs, and that's who we are. We're a group of employers, small and mid-sized employers, that got fed up with the health insurance system, with the escalating costs and de-escalating or deteriorating benefits, and no information, at all, and not knowing the underlying expense that you're paying for with premiums is the major deficiency and major disadvantage employers have. And it's about time we got fed up and we pushed back. That's what we did. Let me tell you what the effect of having people who know inside and out the pharmacy or medical community and the manner in which it works that small employers do not have access to. Some years ago, maybe late 1990s, we got together with an employer in Southeast Missouri. They have about 70 employees. And with dependents, they have about maybe 100 people. But the economics are exactly the same no matter how big or small you are. Now, pharmacy has a component cost of a particular plan is the fastest growing component of that plan. And it's also, the most frequently used component of that plan. And it is the driving force of where your premiums are going because it's an ongoing expense in that the drugs that are being used are maintenance drugs. So everybody's been conditioned to go running to an insurance agent and running to all kinds of gurus with all kinds of analytics and all kinds of, formulas and all kinds of buzzwords that make it appear as if they're going to be able to make your costs go away. We have a pharmacy benefit consultant that many years ago we got to know who worked inside the pharmacy benefit system, which is working for companies like Express Scripts and organizations that service the pharmacy component of the major insurance companies and major employers. He knows inside and out the way the system works. So rather than listen to the jargon that the insurance industry puts out, we go to him for advice. Well, one of the buzzwords of the day is transparency. And the middlemen in the pharmacy world for the insurance system are what's known as PBMs, or pharmacy benefit management companies. Express Scripts is a PBM. Caremark is a PBM. It's amazing to me how few people who purport to be HR professionals don't even know what a PBM is, and I'm not making that up. But that's what they are, and they're the middlemen that arrange for the, discounts, rebates, various other pricing arrangements for insurance companies that the actual policyholder never sees. They actually add tremendous cost to the underlying cost of a prescription. Well, we had an in-depth evaluation of of this particular group this morning, and an in-depth discussion of the performance of the pharmacy cost for this particular group over the last 10 years. The average number of prescriptions that are purchased as a benchmark across the country are 9.5 prescriptions per year per person. And the average cost per prescription, per year, per month per participating member has generally been about $65 to $75 a month. Well, when an employer has control of their program, they can devise a customized structure that dictates how they're going to pay for what their people use, what the solutions are to meet particular needs, and how and where to get the best value, and then who actually monitors what's going on to be able to give them direction to get the best value. In 2008, 18 years ago, this particular plan had utilization where the cost per participating member for prescription utilization was $26.28 a month per employee. At that time, or $26.28 per participating member, including all dependents. At that time, the average cost across the country per prescription per month was running around $52, $53. Now here it is 18 years later. Same group, same business, same benefits. And their prescriptions are running in 2026 an average of $26.39 per participating member per month. That's almost flat over the last 18 years. Now, this is no fluke, because this particular employer is extremely proactive, extremely communicative to his staff, extremely conversant with the people that can help him, our consultants, and knows how to use his benefit dollar. Now, does that mean that his benefits went down? No, his benefits are the same. They have the same deductible, the same out-of-pocket that they had 18 years ago. But what they don't have is an insurance company who owns a pharmacy management company like Express Scripts controlling their medical life. We are getting ripped off, period. And it's about time we began to push back, about time to take control, and about time to demand information and be proactive about setting up the guidelines by which the plan would provide a benefit and access to health care and access to other needs through the system at the best value. Now, their bills go up and down from one year to the next. There have been years when their claims have been up, and there have been years their claims have been down. But that's not the issue. The issue is getting the best net cost for what needs do arise, and then knowing how to forecast and how to plan based on what medical needs and pharmacy needs exist in a group. And just going to insurance agents and just going to get quotes from insurance companies are not necessarily going to be an answer. Costs are driven from the ground up. They are not reduced from the top down. Consequently, if you're looking for answers, you're not going to find it in quotes. You're not going to find it in changing agents. What you're going to do is find it in the information that is necessary to have based on knowing what your needs are and engaging people inside the medical and pharmacy system to give you the guidance to be able to get to the best result. That's how you save money, not by running around getting quotes from insurance agents. Well, what we want to do is there has to be a benchmark. And the insurance company's premiums have already determined what your benchmark is, because built into a premium is the funding for what medical needs exist in the group to begin with. So what we want to then do is to separate the component cost that is part of a premium that represents true insurance. In other words, at what point should an insurance company begin to take the responsibility of paying a bill? And up to what point is the funding to pay those bills better off in the hands of the employer to be able to, control what is spent, when it's spent, and to get the best value. So what we then do is we will then, we need a census from the employer. So we would send that employer a very simple form, and all we need is the age of the participants, if they're male or female, if they're insuring a spouse or children or both, what their zip code is, and then what the employer's out-of-pocket is, deductible and out-of-pocket. Now, what we then will do is we will then price the cost of actual insurance itself, actual protection of a major claim itself. In reality, in any multiple year period, the percentage of people in any group plan that hit 10,000 or more has fallen to a range of 0 to 6%. How high it gets after that, that's where your protection is. So we want to then determine how much insurance an employer can afford not to buy by pricing out the cost of insurance as a fixed cost at various levels of responsibility to the employer. Depending upon the size of the group, will dictate the point at which insurance should take over. The smaller the group, the lower that threshold. The higher the group, the higher the threshold. But we want to determine how much the employer can afford not to buy. And then we want to separate from the control of the carrier the portion of what had been built into a premium that the employer is currently paying, what the carrier wants in the form of monthly premium to pay for what medical needs are already there. Now, the way the system then works is we would then contract the employer with a medical network so they would get the direct benefits of the discounts that the insurance companies get on medical services. We contract them directly with an independent pharmacy management company to get the direct benefit of the discounts on the pharmacy. The premium as a fixed cost would only be a fraction of what they had been paying before. So let's say you had a group of 20 employees and their premiums were $15,000 a month and their deductible was $500. Well, the point at which insurance should take over might be $15,000. And that premium might not be $15,000 a month, it might be around $5,000 a month. And then the remaining $10,000 a month belongs to the employer as needed and just accumulates and only fills in as needed when needed at the discounted price. So, to use a term that we understand, you'd be buying at wholesale pricing for healthcare services instead of retail pricing, which is premium. There's about a 40% difference between premium cost and actual cost. And the employer then retains the spread between what the premium would have been to pay for what service that people are using versus what is, which is the discounted price. And that grows. So we have employers that are meeting today's needs with dollars they didn't invest in premium 6, 7, 8 years ago. We've got groups of 5, 10, 15 employees that are sitting on six-figure surpluses. And we're no geniuses. This is simple arithmetic. And yet, the most difficult thing that we encounter is just getting somebody to listen to us. If we can show an employer what is really happening under the surface, it's eye-opening. And then you can do with it as you see fit. I can't tell you how many times we may talk to an HR person. We just did last week. And that HR person was extremely impressed with what she saw, not because we were geniuses, we just pointed out facts. So I asked her, I said, well, would you let us put a cost model together for you? It's no obligation, no cost. We'll take our time to do that. Oh, I have to ask the owner. And things die usually 80% of the time there. And the owner's decision not to learn cost the employees who are subjected to those plans dearly. Those decisions made in the boardroom are taking money out of the pocket of the employees in the lunchroom. And nobody pays attention to that. I mean, just on administrative cost alone, I showed one employer that the administrative cost in his plan with Blue Cross was $1,500 a year more expensive per employee than if they just separated that function out of the hands of the carrier and just paid a flat rate. And because no matter who pays the bills, the claims the group generates going to be the same. And no matter how they pay for it, the group is going to put up most of the money anyway in the form of premium or actual cost of service. So why would somebody not take a step to have that $1,500 a year in the employee's pocket without taking any benefits away? That's been puzzling me forever and ever and ever. I've had another employer say to me, well, our employees like Blue Cross. I said, well, they probably like Blue Cross because you're picking up the tab right now. But ask them how much they would like it if at the end of each year you assess them $1,500 because that's how much more it costs you to hire Blue Cross to write these checks than to have ABC administrator write these checks. Then do you think they'd like Blue Cross so much? Probably not, particularly if you asked them for that money around Christmas time at the end of the year. So the perceptions, and the inertia is, quite frankly, what has been very deleterious to an employer's position themselves to do anything about what's happening to them. The procrastination and the excesses that I've seen is just absolutely astronomical. I've never seen any place where people throw money away like I have on health insurance premiums, because nobody knows what anything costs. To particular, objections. Well, will my doctor take the plan? Can I go to any doctor? What does my employee? What's the card look like? Will my employee have a card? All that falls into place. How about, a procedure that would cost maybe $1,000 with a premium that would cost $300 with a check? Isn't that more important than what the card looks like? And let's say your doctor doesn't take that card, but there, 50 other doctors that would. Well, where would you like to go? Dr. A that won't take the card and they'll charge you $1,000, or Dr. number 2 through 50 that will take your card and they'll only charge you $300. That's up to the employer, But nobody is suggesting that anyone's dictatorial. That's not the point at all. But priority is labels or value, and if a label transcends value, well, then you pay for it. If value, and with the same quality transcends a label, then you get the middleman out of the way, and you get a much more stable opportunity to use your benefit dollar more effectively. Employers are costing their employees money. Those employees most of the time have to pay to insure their family. And based on some of these excessive premiums that far outweigh the actual cost of services used, they're costing their employees thousands. Maybe they as the employer can afford it, but how about the people that make their business work? I've run into, businesses, some medical practices where the partners that own the practice, they could care less how much things cost because they were doing very well. But their staff couldn't afford to insure their family, and they're in the medical business. I see that over and over and over again. I see that in professional firms, engineering firms, law firms, accounting firms, where the partners are doing just great. So they have Blue Cross. Their wife likes Blue Cross. Their kids like Blue Cross. But Blue Cross is not a healthcare service. All that is an accounting system. That's all it is. Really think about it. What do? They write checks. You're not in healthcare. What do? They write checks. They collectivize all your money. They write checks. Do they provide health care? No. They provide a clearinghouse to handle the paperwork. Centene, they're a clearinghouse to handle the paperwork. Well, if you wanted to hire that clearinghouse, the amount of the excessive pricing of that is unsustainable. So let's pay attention to what really is true. Let's work from the ground up and see what's driving cost and then see how to mitigate costs. That's what this group I just mentioned about the pharmacy management has been doing for years. They are very, very vigilant. As a result, they are very cost effective, very, very cost conscious, very stable, and that they have the same benefit they have today that they had 25 years ago. How many companies can say that? But between Blue Cross, United Healthcare, Aetna, and Cigna, they own the pharmacy benefit management companies that service their plans. Cigna owns Express Scripts. United Healthcare owns Optum Rx. Aetna owns Caremark. Anthem Blue Cross owns Ingenio RX and also is a participant in Prime Therapeutics. You take just those handful of companies, they actually handle and control over 80% of the pharmacy transactions in this country. Does anybody think having concentrated that power into these few people, that the cost of prescriptions are going to go down? Impossible. The way you make cost of prescriptions go down is get away from them. Go to the independents. Go directly to your independent pharmacy. Get rid of the middlemen. Because these companies that I just mentioned aren't going to buy you an aspirin unless you give them the money to do it with in the first place, in the form of premium. So how much are they adding to your cost with premium against the cost of the actual prescription drug in the first place? We've seen markups where independent pharmacies are getting paid less by the insurance companies for a number of drugs than it costs them to put it on the shelf, while the insurance companies are charging these plans hundreds of dollars more than what they're paying out to the pharmacies, who's getting paid at rates less than what it costs them to put on the shelf. Some pharmacies won't even sell some of these prescriptions because they can't keep losing money. And more pharmacies every year are shutting down because the power is growing in the hands of these people. Get away from them. There are other resources out there. Not good. Higher cost, less access. Okay. More impersonal service. Because to give you an idea, if you turn the clock back maybe around 2005 to 2010, there were approximately 40,000 plus independent pharmacies in this country. And right now there are less than 20,000, I think less than 19,000. There are a number of communities that we had been talking with independent pharmacies 5 years ago, and they're gone. And either the pharmacies are gone altogether, or they've been acquired by Caremark or Walgreens or one of the chains. Even some of the regions, the smaller chains are shutting it. Rite Aid, for example, is if they're not already shut down entirely, they're headed there. And I know Walgreens and CVS CVS even have closed quite a few stores. But the pressure on the independent pharmacies is enormous. So if you live in a community where you have an independent pharmacist, just by going and getting your prescriptions there with your Blue Cross card doesn't mean you're helping that pharmacy. You need to get your prescription by having a group plan that is not controlled by one of those big companies. That's what we show employers how to do. What we want to do is to show an employer how they can use the pharmacy, medical, and insurance resources the same way large employers do, to be able to get the same discounts they get. And if you do, the improvement in cost is remarkable. Does it mean you can make the costs go away? No. Does it mean that the improvement is remarkable? It's only remarkable because of the contrast between perception with premium and reality with the cost. People would be in a better position if these companies were forced to somewhat be unbundled. Here's an answer to your question. How many phone companies are there these days? Lots, aren't there? But there are more companies than AT&T, aren't there? All right. In the early 80s, AT&T was a huge monopoly. And Congress, through legislation, forced the uncoupling of that control. And hence the creation of all these independent phone companies. Well, are we better off with a lot of phone companies? Or had we been better off when it was pretty much controlled by just one company? I mean, you've got all kinds of companies out there now. And we use an independent phone company. It's called IT Voice. We had Spectrum at one time. We had AT&T. Now, if AT&T didn't do the job, which in our case they didn't, that doesn't make them a bad company. It means that we just weren't a good fit for them, that's all. So are you a good fit for Blue Cross? Yeah, many people are. But, could you be a better fit someplace else? Well, why don't you find out? That's all. When I tell you don't go to Blue Cross, that the world would be better without them, but the world would be better with competition. And the competition is disappearing because we have tunnel vision on just a few recognizable names that don't do anything more than the non-recognizable names who institutionally can give you a better value if you just check it out. That's all. That's all we're saying. We're not saying they need to go away, they make the world bad. But when you collectivize so much power in so few hands, it could be dog food, for God's sake, or oil for your car or grass seed. If the needs arise and you only have limited places to go, then you don't get what value you could get if you had options. And the only reason why you don't have options is because you're not asking questions. You're not requiring your representatives to bring you information. That's the point. Let's talk about our politicians. If we really think that we're going to be able to legislate our way to lower healthcare costs, we're not being realistic. It's like the international negotiations. All right. Press releases say one thing, the facts behind the scenes are another. All right. On pharmacy, they'll talk, and what they'll do is just basically peripheral cosmetic, but they're not getting to the core issue. And the core issue is you have too much power concentrated in too few hands, and they're not addressing that. And you can't legislate pricing because that's just going to be a detriment to a marketplace. Make the marketplace competitive. That's all we got to do. All right. The legislators aren't doing that. And if they would focus on that, a lot would go away. Okay. Transparency is a word that they throw around all the time. All right. Okay. So, ABC hospitals, transparent. Your bill is $50,000. Okay, they're transparent. They showed you the bill is $50,000. Did you know what it was going to be beforehand? No. And do you know what it could be if you, addressed it in a different way? We found hospitals, charging 3, 4, 5 times what they would really accept for the same service. We've seen hospitals charging 1,000% above what Medicare would pay for the same bill. We've actually seen it. 1,000% markup. Now, is that transparent? Yeah, we charge $1,000. No, what's transparent is, let's see what the true benchmark is and be able to compare something, because when it comes to healthcare, we can't. So we need to be able to benchmark. What would really be interesting is if, medical facilities were required to disclose on explanations of benefit or reports of bills, this is what Medicare pays us, this is what we're charging you. Then let's see costs come down. That'll never happen, but wouldn't that be interesting?